and whether we can prevent things like oxidation. So a potential therapeutic target could be N-acetylcysteine or NAC, or so should we be targeting the mitochondria and the metabolism, or should we be targeting downstream, so there's sort of TLR9 pathways and other things.
Thank you very much, Mary. And if there are no, there is one more question. What other metabolic readouts are you measuring?
I think with metabolism, a lot of people tend to measure with seahorse. We've gone down the GCMS route. So from beyond lactate, we're also looking at production of carbon-13 labeled CO2 and the pentose phosphate pathway as other readouts.
Thank you very much. And I think we have to move on to the next talk. And I would like to invite the Dutch group with Dr. Veldkamp to tell us about biomarkers galectin-9 and CXCL10 are of additional value in the clinical decision-making in juvenile dermatomyositis.
Hello everyone, I'm Saskia Veldkamp. I'm a PhD student from Utrecht, the Netherlands, and today I would like to talk to you about the additional value of biomarkers galectin-9 and CXCL10 in the clinical decision-making process in juvenile dermatomyositis. ADM is a rare chronic systemic autoimmune disease in children characterized by muscle and skin inflammation. Currently, all patients are treated according to the same protocol, including high-dose steroids. And as patients can respond differently to treatment, they are at risk for over and under treatment. They are therefore in need of a personalized treatment strategy, and to achieve this, objective measures for disease activity are needed. Recently, our group validated galectin-9 and CXCL as robust biomarkers for disease activity in GDM, outperforming creatine kinase. After this validation, we implemented the biomarkers as routine diagnostic tests in a laboratory, and the next step was to evaluate their value in clinical practice. We therefore aim to investigate their additional value in the clinical decision-making process in JDM patients as assessed by pediatric rheumatologists. So for all consultations with galectin-9 and or CXCL10 results, between moment of implementation and March 2020, the treating pediatric rheumatologist completed a questionnaire. And in this questionnaire, they reported the additional value of the biomarkers. They could choose between decisive, helpful, supportive, no additional value, distracting, or other. And they had to explain why. We included 212 consultations in 40 unique JDM patients, and in 82% of the consultations, the biomarkers were considered to be of additional value, so either decisive, helpful, or supportive. The biomarkers were most often considered to be decisive or helpful in cases with clinical uncertainty. So, for example, when aspecific symptoms were present. They were most often considered to be supportive when they confirmed the physician's clinical assessment, and they were most often considered to be of no additional value in patients with long-term drug-free clinical remission. Interestingly, the biomarkers were most often considered to be distracting in cases with rising levels in absence of clinically active and in cases with low levels in presence of evident skin disease. So these situations actually indicate the potential that the biomarkers hold. It would indeed be very relevant to know whether rising levels are indicative of an imminent flare and whether the biomarkers are specific for certain tissues only. So these are important research questions that remain to be answered. In conclusion, in the majority of clinical consultations, galectin-9 and or CXCL10 were considered to be of additional value, which supports their further clinical implementation. Also, our results indicate what work still needs to be done. This includes validating the prognostic value of the biomarkers, investigating their organ tissue specificity, and developing recommendations on their use in everyday clinical practice. We all do this with our end goal in mind, which is to offer a biomarker-guided personalized treatment strategy to children with JDM. I would like to acknowledge the support of my colleagues and several foundations, and thank you very much for your attention.
Thank you very much, Saskia. As we are waiting for the questions, can you just tell us whether you have been thinking or whether you have actually tried to look at the galectin levels in any other rheumatic diseases?
Well, thank you for your question. So we haven't looked at galectin-9 in other rheumatic diseases, but there has been a paper recently from a colleague of ours in a different group who measured galectin-9 in juvenile SLE, in which actually performed better than the CXCL10 anti-interferon signature as biomarker for disease activity as well. So that's really interesting.
Thank you very much. We have one question here. Of those visits in which galectin-9, CXCL10 were deemed decisive, helpful or supportive, were there differences in how often galectin-9 versus CXCL10 versus both were drawn? For instance, is one more useful than the other? That's from Kaveh Ardalan.
Yeah, that's a really interesting question, actually. I mean, we currently have developed a diagnostic test in a laboratory in which we always test both biomarkers. And because they had similar performances in our validation study, we now assess their additional value as a combination, so as a combined test. And overall, they actually behaved quite similarly. So they both went up or both went down. We didn't see many discrepancies. But I think it's really interesting to assess if they have any specific properties.
That has something to do with the question that Lucy just posted. If they are so co-correlated, do we need both of these biomarkers?
Yes, yeah, no, that's really something that we need to investigate. We do think that we hypothesize that galectin-9 is more specific for muscle.
Yeah. Okay, so thank you very much. We have to move on to the next talk, which will be on Siglec-1 expression. Whether it reflects the interferon signature in juvenile dermatomyositis and defines subclasses of patients with distinct inflammatory and clinical profiles, by the Dutch team once more, by Dr. Leukenvallekool. I'm sorry if I pronounce it wrong. So the platform is yours.
Hi everyone, my name is Busabong Leukenvallekool. Today I'm going to be talking about our project. Siglec-1 expression on monocytes is associated with the interferon signature in juvenile dermatomyositis, but is superior in predicting treatment response. Siglec-1 is a strongly interferon-regulated marker, and JDM is one of the interferon-driven disease. Then Siglec-1 might be used as a surrogate marker in clinical practice. This study, we would like to first evaluate the relation between Siglec-1 expression, the interferon signature, and disease activity in JDM. Second, to demonstrate whether subgroups of JDM patients with different Siglec-1 expression at diagnosis can predict treatment response. We enrolled 24 JDM patients at onset before starting the treatment, and 10 patients had been followed up until clinically inactive. PCR was used to determine the expression levels of 5 type 1 interferon signature genes, and Siglec-1 expression on monocytes was assessed by flow cytometry. As expected, disease activity, muscle and cell levels, ESR and CRP were highest in the onset group. To first establish the interferon signature within our cohort, the levels of these interferon signature genes and the interferon score were significantly higher in the onset group compared with the other groups. Among JDM patients, the interferon score decreased over time after receiving treatment. For Siglec-1 median fluorescent intensity and the percentage of Siglec-1 positive within CD14 positive cells, JDM patients have significantly elevated Siglec-1 expression at disease onset, which decreased after start of treatment, and correlated with the interferon signature. Both Siglec-1 MFI and interferon score strongly correlated with PGA and CMAT. Next, we stratify patients by median value of Siglec-1 MFI levels and compare clinical disease activity between these two groups. Patients with high levels of Siglec-1 expression has more severe muscle involvement and had a significantly higher frequency of receiving intensification of treatment within 3 months after diagnosis when compared to the patients with low levels of Siglec-1 expression. Finally, we would like to conclude that Siglec-1 may serve as a surrogate marker for monitoring disease activity and predict treatment response in JDM. Siglec-1 may be helped to identify potential candidates for anti-interferon treatment and used to guide treatment decision during anti-interferon therapy. I would like to thank all those who have involved in the research.
Thank you very much, Butabong, for the nice presentation. We are waiting for the questions. I just wonder whether you correlated the interference signature with SIG-like expression. What do you think for the future? Would you be using both in combination, or would you prefer one over another for the purposes that you summarized in the end?
Thank you for the question. I think I would prefer SIG-1 because they have a prognostic value for treatment response further than the interferon signature.
Thank you very much. We have one question by Brian Feldman here. Since the interference signature and SIG-1 are so highly correlated, why is one better at predicting intensification? That's the
it may be because when we do the correlation, we use all of the patient with at onset and also in the follow-up group, so that why they are highly correlated to each other, but the one is better in predicting treatment response.
Okay, thank you very much. So I think as there are no other questions, we will move on to the next presentation by the Turkish group. And I would like to invite Dr. Sag and co-workers from Dr. Özden's group to tell us about the validation of the EULAR ACR 2017 idiopathic inflammatory myopathy classification criteria in JDM patients.
Hi, I am Erdal Sag from Hacettepe University, Ankara, Turkey. I'm going to present our study about validation of the new ACR EULAR criteria for idiopathic inflammatory myopathy in our JDM cohort. In 2017, a new set of criteria was proposed by EULAR ACR. It includes age, muscle weakness, skin manifestations, other clinical manifestations, laboratory features, including anti-J1 positivity and elevated muscle enzymes. This new criteria has two options if the patient has a muscle biopsy or not. Muscle biopsy features were endomysial infiltration, perimysial and perivascular infiltration, perivascular atrophy and lymphocyte. Then, the sum of the scores are converted into a probability by a web-based calculator. The cutoff probability of 55% was recommended. We have included 58 JDM patients and 40 controls presenting with muscle weakness, myalgia, myositis, and skin features in whom JDM is the most possible differential diagnosis. We then compared the new EULAR ACR criteria with Bohan-Peter and Tanimoto criteria. These are the comparison of each criteria between JDM patients and controls. As expected, muscle weakness and elevated muscle enzymes were the most prominent features on both groups, but biopsy features and skin rash were more specific for JDM patients. The new criteria with the recommended 55% probability cutoff was the most sensitive and the least specific one. Specific was lowest because the classical rash is not a mandatory criteria in the new criteria. We then tried to find the optimal cutoff with drop curve analysis. For all cohort, 62% probability performed best, but it only increased the specificity 5%. But in patients with muscle biopsy data, 68.5% of probability cutoff performed best. Due to similarities in muscle weakness and skin features, majority of our multiple acyl-CoA dehydrogenase deficiency patients, interferonopathy patients, and mixed connective tissue disorder patients were misclassified. In our cohort, 75% of our patients had at least one myositis-specific or myositis-associated antibody, but none of them had anti-J1 positivity. Ring glaucoma is an important sign for inclusion body myositis, and it is very rarely seen in childhood. Instead of this parameter, MHC class 1 expression or capillary dropout, which is included in the validated biopsy score tool, might be included. To conclude, the new EULAR ACR criteria performed quite well in our JDM cohort, especially with the probability cutoff of 68.5% in patients with muscle biopsy data. The yield of the criteria might be improved by including the recently identified myositis-specific antibodies and validated muscle biopsy score tool parameters. Thank you very much.
Thank you very much, Erdal, for the clear presentation. So are there any questions from the audience regarding classification? I don't see any questions presented so far. So if there are none, then I suggest that we move on to the next presentation by Turkish group from Cesar Özen's center as well. And that's comparison of IVIG resistance predictive models in Kawasaki disease. So we are moving to vasculitis now, and I would like to ask Dr. Kaya Akça on the screen. Thank you.
Chairpersons and colleagues, I am Dr. Ümmü Şen from Hacettepe University Pediatric Dermatology Department. I would like to present our study comparing predictive models for IVIG resistance in Kawasaki disease. The definition of IVIG resistance is persistent or recurrent fever at least 36 hours after end of the infusion. It may be observed in 10% to 20% of patients. It is important to predict who might develop IVIG resistance for better management and to improve prognosis. We aim to evaluate clinical and laboratory risk factors for IVIG resistance in Turkish children and compare 9 different prediction models. Patients diagnosed with complete or incomplete Kawasaki disease in this time period enrolled to the study. Diagnosis of Kawasaki disease was based on the criteria of the American Heart Association. IVIG resistance risk scores were evaluated and their sensitivity and specificity were investigated. A total of 129 patients with a median age of 36 months were enrolled to the study. 16 patients had IVIG resistance and 44 patients had coronary artery involvement. Young age and high lymphocyte count were independent risk factors for coronary involvement. No difference was noted between the frequency of the clinical and signs and IVIG resistance. In laboratory examination, serum AST, GGT, total and direct bilirubin, LDH and calcium levels were higher in the IVIG resistant group. Risk factors for IVIG resistance were evaluated by univariate analysis. 5 risk factors were associated with developing resistance, but only 2 remained significant in multivariate analysis. Platelet count less than 300,000 and GGT levels were independent risk factors. Young score had the highest sensitivity, while the sensitivity of others were all lower than 50%. The non-predictive model had the highest specificity. Almost all scoring systems distinguished the group of patients with low risk for IVIG resistance, but could not differentiate IVIG resistant patients. In conclusion, the current scoring systems have a low sensitivity in Turkish population. Increased serum GGT levels and low platelet count were risk factors for predicting IVIG resistance. Thank you very much for your attention.
Thank you very much indeed. This was a very interesting presentation because we all look at those predictors when we see Kawasaki patients. I just wonder whether you were able to look at the platelet counts according to the time since the onset of fever.
Thank you very much for question. We took the platelet count after we diagnosed Kawasaki disease. The first, almost all the first parameters we took. The first we diagnosed Kawasaki patients in this Kawasaki diagnosis in these patients. We take the first value in these patients.
I understand, but these could have been, 1 week old or 2 weeks old, depending on when the patient was actually referred to your site. So that was a question. How long from the onset of fever was the first blood count done? That's the point.
In our study, the average time to diagnosis was approximately 10 days after the symptom.
Okay,
Begin.
this was all early. Okay, thank you very much. I don't see any other question around, so if there are no other questions, we can move to the next talk. Thank you very much. And we now have Kavalet score for predicting resistance to first immunoglobulins in Kawasaki disease, confirmation of its good sensitivity and proposal to improve specificity by the French team. And we will hear Dr. Bourgeois.
Good morning, I'm Bourgeois Gladys, and I work in the Department of General Pediatrics, Dermatology and Infectious Disease at Robert Debré University Hospital in Paris in France. And I'm going to talk about Kawasaki disease. Kawasaki disease is the leading cause of acquired heart disease in childhood in developed countries. Cardiac prognosis has been improved by intravenous injection of human immunoglobulin, but around 20% of patients are resistant to a first line of IVIG and have a higher risk of coronary artery abnormalities and require secondary treatments. Thus, early identification of high-risk patients is critical to initiate early aggressive therapies. There are many scores to identify these patients, but they lack sensitivity in non-Asian populations. Recently, Pyramia proposed the Kavalet score to predict IVIG unresponsiveness based on ALAT level, hepatomegaly, lymphocyte count, and time to treatment. With 1 point per variable and a cutoff of 2 points, the score had a sensitivity of 77% and a specificity of 60%. The aim of our study was to validate the Kavalet score in an independent cohort. We analyzed all successive KD patients of our French tertiary center from 2006 to 2019. Patients who had participated in the Kavalet study were excluded, and finally, 186 patients were included. We collected clinical and epidemiological characteristics, Kavalet score, resistance of the first line of IVIG, secondary treatment, and initial echocardiography. Our results showed a median age at disease onset of 24 months, and the distribution of ethnic backgrounds was more diverse in our cohort than in the cohort of Pyramial, with a majority of Sub-Saharan African, Caucasian, and Northern African children. In our cohort, the Kavalet score had a sensitivity of 81.4% and a specificity of 32.7%. And we found that abnormalities at the first echocardiography, defined as presence of coronary artery dilatation, aneurysm, perivascular coronary artery brightness, pericardial effusion, or valvular dysfunction, was associated with the need for secondary treatments. So we tried to improve the Kavalet score by adding this parameter, and we found a sensitivity of 70.4% and a specificity of 59.1%. In conclusion, we confirm the good sensitivity of the Kavalet score, but point out a low specificity in non-Asian populations. Combining the Kavalet score with initial echocardiography abnormalities improves the specificity of the score. Further studies are required to confirm the performance of this new score. Thank you for your attention.
Thank you very much. This was quite on the similar topic as the previous Turkish study, and I wonder it might be really interesting to combine the two sets of data to look at similarities and differences. We have a question here. Dr. Bourgeois from Brian Feldman. How was the diagnosis of KD made? Were they all complete KD?
No, all the KD was not complete. The diagnosis was made by the criteria, and the diagnosis was made by the doctor of the department.
Okay, thank you very much. I'm just wondering, because you mentioned, I see a discrepancy between what you and the Turkish group said about lymphocyte counts, because you said that one of your criteria was low lymphocytes, while the Turkish group, and I would like to hear their comment, said that it was lymphocytosis, if I got it right. So was I right? Could could Turkey comment on that as well? Could we have that? Am I right? Your one was lymphopenia, rather lymphopenia. Correct?
You,
low lymphocytes, that you mentioned, that your patients, your severe patients had low lymphocyte counts. Is that right?
Yes.
While the Turkish said that they had lymphocytosis, if I remember their slide well. Is that right?
Yes. Yes, and I was surprised by this. But in our study, we did not study the association between the lymphocyte counts. We didn't specifically study the association between lymphocyte counts and the need of secondary treatment, but it was made in the study of Piram et al., and it was shown to be associated with the need of secondary treatment when the patient had a low count of lymphocytes.
Okay, thank you very much. I was just wondering the last thing, what was the initial, as you mentioned, initial echocardiography abnormalities? I guess these were not coronary artery changes. These must have been different one done early on. So what was, you did not specify the echo abnormalities. What was it?
It was any abnormalities at the first echography. So dilatation,
like what?
Dilatation, brightness, aneurysm, pericardiac effusion, valvular dysfunction.
I think for the future report, it would be interesting to actually distinguish the coronary artery changes, which I would be surprised to have them so early at the time of diagnosis, from other, echocardiographic changes that may be visible very early on. So that would be interesting to distinguish the type of echo changes. So you don't have that data, I guess. Okay, let's move to the next presentation. Thank you very much. And the next talk will be different histological classifications for henoch-Schönlein purpura nephritis, IgA, vasculitis-related nephritis. Which one is the best predictor of disease outcome? Pilot study by the Press Vasculitis Working Party, presenting by Dr. Held. It's an international activity. Thank you.
Greetings from Zagreb, and thank you for watching this presentation. My name is Mario Šestan. I am pediatric resident at University Hospital Center Zagreb, and I will in brief present the results of scientific project led by Professor Marija Jelušić on behalf of the Press Vasculitis Working Party and sponsored by Croatian Science Foundation. This is a pilot study about different histological classifications for henoch-Schönlein purpura nephritis. As many of you already know, in clinical practice we use different histological classifications, but it is not known which one best correlates with the severity of renal disease and disease outcome. So the aim of this pilot study was to compare the four most commonly used histological classifications for henoch-Schönlein purpura nephritis. This was multicentric cross-sectional study that included 69 patients with biopsy-proven henoch-Schönlein purpura nephritis, and four histological classifications used for comparisons are summarized in the tables 1, 2, 3, and 4. We used four classifications: the International Study of Kidney Disease in Children classification of henoch-Schönlein purpura nephritis, the Oxford classification of IgA nephropathy, histologic classification of IgA nephropathy of Haas, and modified semi-quantitative classification developed by Koskela and others. The clinical outcome was defined according to the modified classification of Cunahan, summarized in the table 5. And complex statistical analysis was performed to analyze the linear relationships between outcome and histological classifications. As it can be seen in the figure 1, the modified semi-quantitative classification developed by Koskela and others proved to be the best in the discrimination of patients with good and poor outcome, followed by the Oxford classification, while the International Study of Kidney Disease in Children which is the most frequently used in clinical practice, and Haas classification were not so successful. When we analyzed the individual variables of Oxford and semi-quantitative classifications, the variables of interstitial fibrosis, tubular atrophy, and tubular dilatation in the semi-quantitative classification, and endocapillary hypercellularity and crescents in the Oxford classification showed the best association with the outcome. To conclude, the semi-quantitative classification developed by Koskela and others has the strongest association with the severity and outcome of Henoch-Schönlein purpuranephritis, followed by the Oxford classification. Although crescents on renal biopsy were considered the most important outcome indicators, the pilot study suggests that tubulointerstitial changes could be even more important as predictors of poor outcome. In the end, I would like to emphasize that we plan to expand this project to other international centers for pediatric rheumatology and nephrology, and we would like to invite all interested clinicians and scientists with biopsy-proven patients with Henoch-Schönlein purpuranephritis to join us. Thank you for your attention.
Thank you very much, Mario, for the presentations. I wonder, I would like to hear how many patients from your IgA vasculitis patients actually had IgA nephropathy, and based on the histopathology findings, what clinical or therapeutic implications did you have?
Well, thank you for the question. I think that about 1/3 of patients in our cohort developed renal involvement, and 1/3 of them were biopsied. The clinical features or the clinical picture course of these patients was quite different, but most of them present with mixed macrohematuria and significant proteinuria. Some of them.
I mean, only what was your therapeutic decision based on the biopsy?
Well, yes, we used biopsy as in our therapeutic decision. I know that still the therapeutic regimes for purpuranephritis are not based on histology, but in our work we used it, especially in patients who were resistant to previous therapy and who have severe renal involvement.
Okay, so thank you very much, Maria. We have to move to the next talk, which will be by the Turkish group, and we will hear about pilot proteomic analysis of plasma biomarkers in IgA vasculitis by Dr. Demir from Dr. Özden's group. Please.
Dear chairperson and colleagues, I will present you a pilot proteomic analysis of plasma biomarkers in IgA vasculitis. IgA vasculitis is a systemic vasculitis and characterized by the IgA immune deposits in the small vessels. Although IgA vasculitis is the most common vasculitis of childhood in this part of the world, we still lack detailed information on the pathogenesis and markers that can predict the course of the disease. In this study, we aim to analyze plasma proteomes of IgA vasculitis patients using nanoliquid chromatography, tandem mass spectrometry to investigate the disease pathogenesis. In this pilot study, we had 5 active IgA vasculitis patients and 2 age and gender matched healthy children. Serum samples from subjects were collected on the same day of IgA vasculitis diagnosis and before any immunosuppressive treatment was initiated. We investigated the alteration of serum proteome using the nano-LC-MS approach. As a result, we had 345 proteins per sample. And after the data were log transformed and 2-sample t-test was performed between 2 groups, we identified 23 significantly different expressed proteins. In this table, we can see the list of differentially expressed proteins identified in IgA vasculitis patients compared to healthy controls. The levels of complement C3, apolipoprotein E, glyceraldehyde triphosphate dehydrogenase, filamin A, alpha-1 beta-glycoprotein, tubulin beta-1 chain, lipopolysaccharide binding protein, and IgMu chain C region were significantly higher in IgA vasculitis patients compared to control groups. Also, in this heat map graphic, we can see that IgA vasculitis patients and healthy children gathered separately. In conclusion, the proteome of active IgA vasculitis patients and healthy children differs significantly. As I said before, it was just a pilot study, and our study is ongoing in a larger group with 45 patients and 6 healthy children. However, this pilot proteomic study may provide us a perspective in the pathogenesis of IgA vasculitis and possible personalized treatment. Thank you for listening.
Thank you very much indeed. This was very interesting. Do we have any questions from the audience? So far, I do not see any. So we wish you good luck for your further extension of the study, and we will go ahead to the next presentation. We are not going ahead with the next presentation. We have probably finished. Am I correct, organizers? Any further questions from anybody to anybody at the moment? We are about to finish the session. I'm sorry, I just did not recognize you were the last one. Salchan. No more questions? If not, then I have to thank all the presenters and all who were listening and wish you a nice end of the Congress. A nice evening. Bye-bye.